dose and drip, he starts talking in that paragraph about that night. He goes, not the same dose on that time. He's dose and drip, but not the same dose that night. Well, he doesn't correct himself. I did not give him a drip. He's correcting Detective Smith.
When he says, I've given it to him before, and he handled it fine, Detective Smith then just says, it's a question, the same dose?
And he goes, the same dose and drip.
And then Dr.
And then he
Murray
explains
says,
a lesser dose.
The dose and the drip.
Mm-hmm. Dose and the drip.
And then he says, not the same dose in this case, because I had given him earlier Versed.
Mm-hmm. He didn't say I didn't give a drip. He said I gave a drip, dose and drip. Can we agree to disagree?
I
Well,
guess
don't.
I'm sorry.
Don't ask questions.
Sorry.
Mr. Flanagan will, and then we'll have answers. And we're dealing with 352 territory here. Thank you.
it's just not, it's not too clear, is it?
I will agree with you. It's not completely clear. But in my, can I say, it appears to me, and it makes logical sense, because when someone is placed on propofol for sleep, 25 milligrams is, again, a small dose that we give as a bolus prior to putting an infusion in. And so it's logical that there is a drip. He was giving a drip every other, you just told me he was giving a drip every other night, including 2 other nights ago. He references the drip at least 3 times. So logically, it seems he should be on a drip. He was sleeping still. Because if I would give propofol, he should not have gone to sleep for a long period of time.
Okay, logically, if he wanted him to sleep for an extended period of time, he'd follow it up with a drip.
Correct.
But he doesn't actually say he did that, does he?
Again, I disagree.
Okay. Now, we were talking about this 25 milligram dose. That's not a very heavy dose, is it?
No.
And if given to him over a 3 to 5 minute period of time, perhaps if he has no lorazepam in him, that doesn't even get him to sleep, does it?
Probably not.
It's a very small dose.
Yes.
It'd be a mild sedation dose, wouldn't it?
I don't know. I don't know if it's a mild sedation dose.
Okay. But when he gives him that over 3 to 5 minute period of time, Mr. Jackson does go to sleep.
Yes.
Now, assuming that that amount of propofol was what put him to sleep, how long would you expect that propofol to keep him asleep?
Probably less than 10 minutes. If
Other
that at all.
people said anywhere from 4 to 7 minutes. Would
Fine.
you
4 to
agree with
7,
that?
I agree, yeah.
And how long would you expect for the propofol to be in his bloodstream, having an effect on him?
Sustained.
Is that beyond your area of expertise?
Probably, but I will agree with 4 to 7 minutes, probably.
Now, in the event that he sleeps beyond the 4 to 7 minutes, would you conclude from that after giving that type of a dose, 25 milligrams, if he were to sleep beyond the 4 to 7 minutes, that the sleep would not be the product of propofol?
I probably would agree.
Okay. But there's other things that keep people sleeping, isn't there?
Yes, sir. I would be a little concerned, yeah.
Fatigue will cause you to sleep, won't it?
Fatigue can cause you sleep, yeah.
Okay. Now, he'd been fighting sleep all night for, at this point in time, at least 9 hours, maybe 10 hours, trying to go to sleep. And he finally nods off and goes to sleep with a... You think that just being tired could account for him being asleep?
I don't know, but I would be, I have no idea, but I'd be very concerned that he's still sleeping. The protocol for propofol is that when we give propofol, after its effects, we check on the patient to make sure they're back to their pre-sedation level. So the fact that he was still asleep, I agree, is concerning.
Okay. But in any event, he's sleeping. And Dr. Murray is watching him for several minutes and defines the sleep as he wasn't snoring, it was just kind of a moderate sleep. Correct?
Well, that wasn't defined. We define how deep someone is asleep when what we do is we have score, we check on them. Again, as I said, moderate sedation is a twilight state. They even nickname it conscious sedation. And they would be arousable to talking. It would be responsive to touch. And a deep sedation is, the definition, is responsible for painful stimulus. So when we give people sedation, we constantly assess their sedation level. So the fact that just looking at the guy and he's sleeping, you cannot make an assessment whether this is moderate or deep. I would say it's probably deep.
Can you make an assessment by looking at the pulse oximeter?
No.
You know his pulse is normal?
Yes.
You know his oxygen saturation is normal?
Yes, sir.
You've known this individual, you've watched him sleep many, many nights, and you determined that this is not a deep sleep?
No, I did not determine it's a deep sleep. He didn't assess, he didn't try and arouse. When we give propofol, I make sure that the anesthesiologist, when I give propofol, it's similar to this situation. For a cardioversion, they usually give a little bolus. Again, I'm going to pretend that the guy wasn't on an infusion. But if you give a bolus and you put people to sleep briefly for the cardioversion, again, the patient's usually awake after 7 or 8 minutes, and the anesthesiologist is there making sure that they're back to their level of previous, because propofol wears off very quickly.
You're talking about the use of propofol for deep sedation.
Absolutely.
Okay. Well, Dr. Murray was just trying to get a person who had a severe case of insomnia to go to sleep. Is it your opinion that once he's given him a drug that that drug is going to keep him to sleep for about 4 to 7 minutes, and he continues to sleep past the 4 to 7 minutes, and Dr. Murray continues to watch him? Is it your testimony that Dr. Murray should have tried to wake him up
Absolutely.
before?
Absolutely. When you give propofol, you have to always assess the sedation level, and you do not leave a patient unmonitored until they're back to their pre-sedation level. You don't give propofol for sleep. That's not an indication for the drug, and that's an extreme deviation of standard of care. So if you're telling me, first of all, that there was no infusion, and he gave 25 milligrams of propofol, and the guy was still sleeping after 7 or 8 minutes, I'd be concerned that there's something going on, and you absolutely need to stay there and monitor them until they're awake. You do not leave their side.
Now, Dr. Murray just spent 9 hours trying to get him to sleep. And now you're telling me he should awaken him.
He shouldn't have been putting him to sleep in the first place. The propofol is not indicated for sleep. And absolutely, if you give propofol and afterwards they're still sleeping and something's wrong, you need to arouse the patient and you need to figure out what level of sedation is, because something could be going wrong.
So we get back to your position that propofol just cannot be used for insomnia.
Yes.
Can't be used to just induce REM sleep.
Yes.
This states the testimony is talking about standard of care.
Overruled. Now, and you've never heard of a doctor using propofol for sleep?
Yes.
Yes,
I've never heard. I'm sorry. I've
No,
never.
that's the correct answer.
Okay,
It was
was
a
it?
negative question, and you answered.
Yes.
Yeah.
Are
You
you
agree?
I've never heard of anyone giving it for sleep.
Are you familiar with a study published in Cell Biochem Biophysics this year titled Propofol-Induced Sleep, Efficacy and Safety in Patients with Refractory Chronic Primary Insomnia.
I am familiar with that.
And that was a study done with about a 100% success rate.
Yes, sir.
And that was propofol was used?
Yes, sir. Can I expand on that?
Sure.
Okay. There's a lot of issues what you're bringing up. First of all, that article was published, first of all, in 2010. And so that's way before Dr. Murray gave that propofol. So when he gave the propofol, there was absolutely no medical knowledge that you can give propofol for sleep. Second of all, when we give something off-label, we need to make sure there's some bit of data that's indicated, and there wasn't any in 2009. There was not even anything. So the fact that he was giving it was unethical because there's absolutely no data. The other thing is this paper that you're quoting gave propofol for 2 hours for 5 straight nights, not propofol overnight for 2 straight months. So the fact that even if that article was published before, it would be unethical to give him propofol as well as exfoliate the data from there to giving it for extended period of time.
The article does indicate that propofol does work for insomnia, doesn't it?
Yes,
And refractory chronic primary insomnia.
I think so.
Do you have any idea what type of insomnia Mr. Jackson had?
I'm not a sleep expert.
Okay. The fact that this article is published at a point in time after Dr. Murray was using propofol does not mean that it would not be a viable source of treatment, does it?
No, absolutely. It means it is absolutely not a viable source of treatment because it is untested, unethical to use a drug off-label with no data.
Okay. Do you think it would be a viable source of treatment now?
No, still not.
Why not?
Because anytime there is a study, it has to be extensively done on multiple patients, and some society, like let's say the Sleep Society, would have to comment on it in order for it to be used safely off-label. Because the way you're describing it, it's still experimental. So if someone wanted to use propofol in this situation with that one article, they would have to go through an IRB, a research institute, and get it approved through an ethical board before testing it. So the fact that he was basically doing primary research with no overview.
This study, there was 64 patients given a therapeutic dose of propofol, and it had a 100% success rate on not only being therapeutic, but curative, didn't it?
I'm unaware of curative.
6 months later, they tested the same people, gave them additional tests, and they were all better, weren't they?
I think there was improvement. I don't know if anyone, I don't know the exact numbers. I've not reviewed that article in a while, but I can comment. If Dr. Murray would have given propofol for 2 hours for 5 straight days, like this protocol did, maybe I would give him a little bit leniency. But the fact that he did not do that, so that does not apply.
Well, now you do know that of a doctor that's used propofol for insomnia, don't you?
Yes, I know those doctors.
Okay.